Okay, so I was tasked to lecture on the thalassemia and G6PD deficiency. Um, okay, so please allow me to speak in Taglish in order to emphasize more on the subjects that I will be presenting. So first is thalassemia. Uh, we will cover more on alpha thalassemia because sa mga hindi pa po nakakaalam, newborn screening, G6PD is the most common. Yun ang laging nagpa-positive. And since nagkaroon tayo ng expanded newborn screening, alpha thalassemia ay mas common na kaysa sa congenital hypothyroidism. Okay, my objective to provide basic information about thalassemia. Okay, I will start it with hemoglobinopathies, which is the group of blood disorders and diseases. Further categorized into two, the hemoglobin variants and the thalassemias. Okay, so if we say hemoglobin variants, this will the unusual genes that affect the quality and structure of hemoglobin. And for thalassemias, these are the unusual genes that affect the quantity of hemoglobin. So for hemoglobin, carries oxygen to body's organ and tissues. Okay, we will concentrate on thalassemias. What is thalassemia? It is inherited blood disorder that causes anemia. We have the basic nomenclature of thalassemia. First classification is genetic or genotype, and the second is clinical, the phenotype. For genetic, we have alpha thalassemia and beta thalassemia, wherein there is a defect in alpha and beta globins. And for the phenotype, we have thalassemia minor or the trait carrier. This will be asymptomatic or mild anemia patients. Thalassemia intermedia, these patients will be having moderate anemia or intermittent transfusions, blood transfusions. For thalassemia major, these are the severe, magkakaroon sila ng severe anemia and may be transfusion dependent po sila. Okay, so sabi ko alpha thalassemia tayo, masyado pong marami kapag ititakal natin ang thalassemias and also the hemoglobinopathies. For alpha thalassemias, sa mga may na-encounter na po, we have 5 classifications. Isa, normal, kapag 4 po yung alpha genes. Second, yung silent or carrier kapag 3 ang alpha genes na meron. And third is the alpha thalassemia kapag dalawang alpha genes ang dead or wala. And the HBH disease or the alpha thalassemia, isa lang ang alpha gene na mayroon. And for kapag wala po, these are the hydrops fetalis na tinatawag natin. So sa newborn screening, we are for newborn screening continuity clinic, we are more on monitoring this HBH disease or the alpha thalassemia patients, the 3 gene deletion of alpha genes. Okay, to further explain, we have the legend here. Normal globin gene, alpha globin gene, deletion, and non-deletional mutation. Pag mutated, kasali din po yun. Okay, pag sinabi nating normal, 4, and pag carrier, isa lang. Ang deleted or mutated gene, alpha gene, kapag alpha thalassemia minor or dalawa, yung 3, these are the alpha thalassemias or HBH disease. And for hydrops fetalis, ito yung walang alpha gene. Okay, so para mas matatandaan nyo po, kahit ma-share ko lang po ito, kapag sinabing carrier, yun yung ituloy nyo lang yung C to O, only one ang deleted. Kapag yung trait, two are deleted. And kapag yung HBH disease, ito na yung tatlong deletions. Okay, para mas matatandaan nyo po. What are the inheritance for thalassemia? Autosomal recessive. Okay, kapag sinabi nating autosomal recessive, dapat both parents will are affected para magkaroon sila ng thalassemia baby. Okay, mag-start po tayo dito. When one parent is a carrier only. So, kung normal yung nanay, wala silang magiging anak na thalassemia. But, meron 25% chance ng lalaki magiging carrier. So, okay. So, next, kapag both parents are carrier, there is a 25% chance na magkakaroon sila ng anak na thalassemia. Okay. And if one of the parent is thalassemic and their father or one of the parent is a carrier, there is a 50% chance that their babies will be having thalassemias. And for the other 50%, they are going to be carrier. Okay? And for the last one, both parents are patients, meaning thalassemic sila. Lahat ng magiging anak nila will be thalassemic patients. Okay. So, what are the thalassemia treatments? Lifetime condition. This is the lifetime condition. So, continuous po yung treatment. Some patients will be having blood transfusions. Some will be having iron chelation, bone marrow transplant, which is 80 to 90% success rate, and stem cell therapy, and folic acid supplementation. For alpha thalassemias under continuity clinics in the whole Philippines, we are more on the folic acid supplementation. Some of our patients require blood transfusions also. Okay, next. Glucose 6-phosphate dehydrogenase deficiency. I know lahat kayo ay naka-encounter na ng G6PD deficient patients. Okay. So, sabi ko kanina, this is the most common disorder screened and confirmed in the newborn screening panel of disorders. My objective is to understand the basics of G6PD deficiency. Okay, the outline, basics of G6PD deficiency and the data in NBS continuity clinics, and also the collecting facilities. What is G6PD? Okay. It is one of the enzymes that helps the body to process the protein and turn to energy. It helps protect the RBC against oxidative substances from certain foods, drugs, and infections. So we will not be discussing all of this, pero I want you to visit www.newbornscreening.ph for more information, not only for G6PD deficiency, but for the whole newborn screening program of the Philippines. Okay, how G6PD protects RBCs? The G6PD produces NADPH, the coenzyme that maintains the supply of reduced glutathione. So this glutathione will clean and protect RBCs from oxidative stressors. What is G6PD deficiency? It is the absence or lack of G6PD enzymes that will result in the inability of the erythrocytes or the RBCs to detoxify oxidizing agents. Okay. G6PD deficiency was discovered in 1956 and the most common human enzyme deficiency, also known as the fabism, kasi natitrigger siya agad kapag nakakain yung baby or yung patient ng faba beans. Okay, we have the clinical manifestations for G6PD deficiency, hemolytic anemia, and neonatal jaundice. Signs and symptoms of hemolysis: we have anemia, jaundice, irritability, tea-colored urine, splenomegaly, backache, and poor sac. Okay, so some of you may encounter this for the first time. There are 4 variants of G6PD deficiency. And I want you to get a piece of paper and a ball pen kung gusto po ninyo, or sige, titignan nyo na lang. We have mild G6PD deficiency, moderate, severe, and very severe. Paano natin na-determine to? Because of the residual enzyme na tinatawag. So may less than 2%, less than 10%, 10 to 50, and 60 to 99%. Okay. How to compute for residual enzymes? So paano ba to? Okay. Tingnan nyo po yung yung sample ko dyan. This was taken October 20, 2020. Okay. So, paano mo malalaman yung result is under very severe or moderate or mild? Okay. First, you have to check for the age of the baby when the collection was done or the confirmatory test was done. Okay, this patient was 1 month old. And the reference range is 1 to 6 months old. Okay, now check the result, 0.56. Check your cell phones. Calculator, please. Thank you. Open nyo na po. 0.56 times. Okay. You have to divide this to the reference range under 1 to 6 months old. Okay, 14 point divided by 14.77 times, multiply this to 100. Okay, ano po lumabas? 3.79 or 3.8, which will fall under, hindi kasama sa very severe, pero dito sa severe, less than 10%. Tama po. Okay, so at least may na-share po ako sa inyo. Okay, G6PD deficiency is not that lethal naman, di ba? Ano ba ang implication nito, variants na to? Ibig lang sabihin, kapag mas mataas ito, yung result, mild, i-compare mo sa severe, mas madaling magkakaroon ng simptomas si patient na severe kaysa kay mild. Yan. Okay? So, G6PD deficiency, mode of inheritance, X-linked recessive. Okay, pag sinabing the mutated gene causing the G6PD deficiency is located in the X chromosome. This is the reason why males are commonly affected. Okay. Okay, this is exciting. Genetics. In newborn screening continuity clinics, we do genetic counseling as part of our work. Okay, we have the inheritance. Kapag pinakita ko po sa inyo ito, nakakalito, right? Usually these are posted in online and Google. Pero gusto ko lang makita niyo nito. The share is XY pag sira yung X chromosome, deficient kapag ang babae, both X chromosome ay sira, at carrier kapag babae ay isa lang ang sirang X chromosome. Okay. So we have to simplify this further. Oh. Okay. So X-linked recessive, affected is father. Kaya nanganak sila niyan ng lalaki, for sure normal yung mga, kasi pasa mother is normal X chromosome. Wala siyang unaffected kasi. And for babae naman, kapag nanganak sila ng babae, magkakaroon sila ng chance na magiging carrier. So wala namang magiging G6PD deficient sa kanila dahil normal yung X chromosome nila. Kahit mapasa ni sir, which is G6PD deficient, yung sirang X chromosome niya. Okay? So medyo nalilito pa yung iba. Next. X-linked recessive is yung carrier naman is yung mother. So, normal yung X chromosome ni sir, yung X chromosome ni mother, isa kasi carrier siya. Okay, kapag nanganak yan ng lalaki, normal pa rin kasi may possibility na normal pala dahil pwede niyang mapasa yung normal X chromosome niya at yung tatay, mapapasa niya yung Y chromosome. So, next, kapag babae yung anak, pwedeng maging normal din. And yung pangatlong babae dito, pwedeng magiging carrier. Bakit? Kasi mapapasa ni sir yung normal X chromosome niya. Yung mother naman, mapapasa niya, possibly, 50% chance yung X chromosome na sira. Kaya pwedeng maging carrier yan. But for lalaki, may 50% chance silang magkaroon ng anak na lalaki na may G6PD deficiency kasi dalawa, yung X chromosome, yung isa, normal, and yung isa naman, affected or sira. Okay? So, kung nalilito pa rin, here is another example. Okay. Sa genetic counseling, part ng counseling ng newborn screening continuity clinic, sabi ko mayroon yan. Okay? So, tingnan niyo yung 0.56 ito yung patient and male ito. Okay? So, paano ba yung start ng genetic counseling sa G6PD deficiency? Okay, so titignan nyo, nandun yung brochure binigay ko, nakalagay dyan yung drawing. Okay, sasabihin ko mamaya. So, yung patient natin is yung pinakadulo, yung XY, which is lalaki. 0.56 yung results to confirm. So, ganito yan. X and Y, patient natin, susundan po ninyo kung gusto po ninyong matutunan dahil mas madali pong i-explain sa mother pag nagtanong sa inyo if bakit si ganitong anak ko normal, bakit si ganitong anak ko deficient. Okay? So, XY, this one. Bakit yung X niya is sira dahil confirm nga siya doon na may G6PD deficiency siya. So, magtatanong ngayon si nanay sa katatay. So, i-explain mo, nagkaroon kayo ng anak na G6PD deficient mother, na baby, kasi napasa ni sir yung Y chromosome, napasa nyo yung X chromosome ninyo. Unfortunately, mother, yung X chromosome nyo is sira. Okay? Next, sinabi niya sa akin, mayroon pa akong 3 anak. Yung panganay ko, XY, yung pangalawa, babae, yung pangatlo, babae ulit. Pero bakit yung pangalawang anak kong babae ay mayroong G6PD deficiency? Yun yung lumabas sa result ng newborn screening niya. Okay? Nagpa-confirm. Okay. So, i-explain mo yan. Yung first baby mo kasi ma'am, kaya siya normal. Bakit daw normal ulit yung lalaki na anak niya? Yung isa hindi. Napasa kasi ni sir yung Y chromosome at napasa ninyo yung X chromosome niya normal. So, ibig sabihin ngayon yan, the mother is affected. Okay? Carrier. Okay, carrier. Kapag affected, 2 X chromosome sira. So, carrier lang siya. Ngayon, bakit yung pangalawang anak ko naging yung babae ay confirmed? Dahil napasa mo yung X chromosome na sira and napasa ni sir yung X chromosome niya which is sira. So, i-explain mo ngayon na si Mr. nyo ngayon is mayroon siyang G6PD deficient din. Okay, mapapatunayan yan dahil confirm po yung pangalawang anak ninyo na may G6PD deficiency. And the last one, bakit normal yung anak na babae? Kasi napasa mo ma'am yung X chromosome na normal and napasa ni sir yung X chromosome na sira. Okay? I hope na-gets nyo po yung ibig sabihin. Sa newborn screening continuity clinics na nakikinig, I know marami kaming na-encounter na ganito. Meron yung 5, 6 pa yung anak. So, you need to explain why nagkaroon ng ng ganitong anak yung family, yung father and mother. Okay, for G6PD deficiency treatment, wala pong gamot ang G6PD deficiency, only preventive and supportive. So prevent yung mga bawal or yung mga dapat i-prevent and supportive, support natin yung baby hanggang paglaki, ma-explain sa kanya that these are These are kailangan i-avoid, okay? So for data naman, we have as of May 31, 2018, these are endorsed to NBS CC only 1,898. Okay. G6PD data from NSCCL. So bago lang to. Look at this. Total ang positive nung 2019, 1,227. Pero ang confirmed for 118 and 1 normal. So iilan lang yung nagpa-confirm. Only 1/3 of patients positive of G6PD deficiency are subjected for confirmatory test. Dami dyan, hindi nakaka-confirm. Why? These are the possible reasons. Financial, the cost of G6PD deficiency confirmatory is 400 pesos. Second, geographical location, malayo, and availability of confirmatory centers. So, for Luzon, we have these confirmatory centers. For Region 1, tatlo po. For Baguio, we have Baguio General Hospital Medical Center, started last September 2018. Okay, Cagayan Valley Medical Center, nilagay ko din dito kasi yung ibang patients pumupunta din doon, and EUFMC. Okay, bago lang tong Bataan sa natin. Also, dito sa baba, DOH CAR have identified NBS confirmatory test collecting facilities. This is the first collecting facilities na na-develop sa buong Pilipinas through Dr. Narciso. We have the list in DOH CAR sa mga confirmatory test collecting facilities. Kapag ito sa mga pasyente malayo sa confirmatory centers, pupunta sila sa mga collecting facilities and they will facilitate the collection and sending of bloods and specimens to the confirmatory centers. Okay, hindi lang po G6PD deficiency ito. Kasali na po dyan ng mga CAH, mga ating mga and other metabolic disorders sa NBS. Okay, so that's all. Maraming salamat po sa pakikinig. I hope marami po kayong natutunan.